serves as the Medical Director of Care Experience at Henry Ford Health, where she leads at the intersection of clinical care, the medical humanities, and culture change. Dr. Rena Oddish is the best-selling author of In Shock, a landmark medical memoir. She serves as the Medical Director of Care Experience at Henry Ford Health, where she leads at the intersection of clinical care, the medical humanities, and culture change. A clinical professor at both Michigan State University College of Human Medicine and Wayne State University School of Medicine, she has been nationally recognized for her impact on healthcare transformation, including the Schwartz Center's National Compassionate Caregiver of the Year Award in 2017 and recognition as a U.S. News & World Report Healthcare Hero in 2020 for her leadership during the COVID-19 pandemic. Her writing has appeared in the New England Journal of Medicine, JAMA, Harvard Business Review, and the Washington Post, and her voice has been featured by NPR, BBC, CNN, The Atlantic, and Self. She is widely regarded as a leading thinker on the moral and emotional dimensions of caregiving and healing. Her follow-up book, Aftershock, which has been described as a piercingly honest, insightful, deeply vulnerable examination of the true nature of healing, will be published in June 2026 by Macmillan.
Thank you. I am so honored to be standing here before you, and I'd like to dedicate this talk to my friend Tiffany Christensen. For one thing, she would have loved to be on this stage addressing this community. So with deep humility, I do this in her honor. I met Tiffany in 2017. We were both speaking at a patient safety conference in Connecticut. Tiffany was born with cystic fibrosis and had her life extended by 2 double lung transplants. I can't tell you how grateful she was to this community. She was working as a patient advocate and trying to affect change from outside of medicine. And I was working as a pulmonary and critical care physician trying to affect change from the inside. My path to that conference and meeting Tiffany was similarly harrowing. At the end of my fellowship and 7 months pregnant, a vascular tumor that I didn't know I had ruptured in my liver, sending me into hemorrhagic shock. I was wheeled into the operating room with lab values that didn't sound survivable to me. I had a hemoglobin of 3, platelets of 15, and AST and ALT that were in the tens of thousands. In just that first night, I received 26 units of packed cells, additional cryo and platelets and FFP. I went into multi-system organ failure, and of course, we lost the pregnancy. In the operating room, the last thing I heard the anesthesiologist said was, "We're losing her. She's circling the drain." In that moment, I knew he was right. I felt small and weightless. I could see him trying to place access. I'd gone in with only 1 small peripheral IV. I could see the obstetrical team. They were readying with instruments to extract the baby. And I realized I could see myself on the table. And in that moment, I felt completely at peace. The pain that had brought me in was gone. I felt weightless and buoyant. And I remember knowing in a wordless way that I had to make a choice. I could choose to leave the pain and my body, but that would mean leaving everything. Or I could choose to stay. And I still don't remember choosing, but I remember waking up in the surgical ICU to the voice of my childhood priest who was making the sign of the cross on my body. As an intensivist, I would have rather woken up to ECMO, honestly, because having my priest there just meant they didn't think I was going to live. That first catastrophic night led to endless surgeries and procedures, attempts to repair what could be repaired and remove what couldn't, which ended up including half of my liver. I left the hospital months later in a wheelchair. I was on oxygen from trapped lung. I was inarticulate and very slow from the hypoperfusion. I'd had a stroke to my cerebellum, so my balance was terrible. I was effectively disabled. And to be honest, I didn't recognize myself anymore. Everything I had known myself to be, a physician, an expectant mother, an able-bodied person, was gone. And the new questions, the identity questions, the emotional questions, the grief, it all aligned perfectly with what medicine had difficulty addressing. I came out of that time astonished by what medicine could do. There is no question that I survived something unsurvivable, and I revered medicine. I worked so hard to be able to come back and practice as a physician. But there were also things I saw that disturbed me. I saw how difficult it was for us to sit with suffering that we couldn't fix, to just attend to grief. I saw how medicine had not trained me to have love and reverence for a disabled body. I knew how to fix things. And if I couldn't fix them, then I knew how to suppress and control them, at least, in the ICU. I came out of that time believing that medicine couldn't heal in a vacuum. It wasn't just about the treatments. Medicine required connection. And connection would require that I learn to communicate differently. I had to communicate with more compassion, frankly, than I'd been trained to. This is Tiffany and I presenting a joint keynote at IHI. Tiffany could not understand my obsession with compassionate communication. Like, we would fight about it. She genuinely thought that empathy was just added fluff. And I didn't understand it at the time, but in retrospect, I think that imprecise empathic statements could sound like pity to her. She'd gone her whole life in a sick body and was genuinely awed by it. She didn't understand why medicine didn't give sick bodies the reverence that they deserved. And she thought if we did, we wouldn't just learn to talk to them differently, we would actually treat them differently. When Tiffany was still very young, her first transplant failed, and she had to come to peace with the fact that she was going to die. Her description of that time was almost incomprehensible to me. She accepted her failing body and loved it anyway. She held reverence for what it could still do, even as it shut down. In fact, when she was ultimately offered a second set of lungs, which had never happened previously at her transplant center, she described being genuinely irritated. Living was going to disrupt her sense of peace. Ultimately, of course, she accepted the lungs graciously, and that experience was really foundational to her work in patient advocacy. She wanted her teams to view her as a true partner. She wanted them to be competent. She had someone else's lungs. They needed to protect them as fiercely as she did. She wanted them to be communicative, but more importantly to her, she wanted them to respect the profound healing capacity of her body. And I don't know that medicine was really designed with reverence for sick bodies at the center. You may recognize this iconic painting. It's called The Treachery of Images by René Magritte. So this is not a pipe. It is a stunningly accurate rendering of a pipe, but it itself is not a pipe. Every day, we look at representations of our patients. We scan flowcharts, we scroll through imaging and lab studies, and we believe that we're seeing our patients with some measure of fidelity. When Abraham Verghese talked about the semantic differences between the patient who lived in the computer and the patient who lived in the bed, he cited the philosopher Alfred Korbitsky, who said that the map is not the territory. The map is not the territory. Anyone who's tried to navigate this conference center looking at a map understands that in their bones. The map is not the territory. But I would argue that nearly everything we look at in medicine is the map. It's impossible to grasp the full dimensionality of a place by viewing a scaled down, flattened model of it. It's impossible to find reverence for sick bodies when we confine our gaze to representations of those bodies. We have to allow ourselves to see the full messy whole. So speaking of representations of bodies, this is Christina's World by Andrew Wyeth. Christina Olson lived on a neighboring farm to Wyeth in Maine, and she suffered from a neuromuscular disease. It's been postulated whether it's Charcot-Marie-Tooth disease or a form of polio or even chronic Lyme. But for whatever reason, she chose not to use assistive aids and to instead drag herself physically across the field. Wyeth saw this as incredibly inspiring and was moved to paint this. Christina would have been in her mid-50s at the time of this painting, although she looks younger because Wyeth chose to substitute the body of his younger, more attractive wife for Christina's larger, more disabled body. In fact, we're not even really looking at Christina's perspective. We're looking through Wyeth's eyes. This is actually Wyeth's world. And it's interesting, he said that he sometimes wished he had just painted the field and left you to imagine Christina there. He had considered erasing her completely. He wanted to extract and take credit for the beautiful inspiration without being burdened by her disabled body. This is how I was presenting my experience. I was trying to take credit for the beauty of the recovery without really acknowledging my own disabled body. It felt a lot more like this. So this is a painting called The Subway by George Tucker. During the pandemic, when I was caring for COVID patients and also somehow expected to homeschool a young child, one day I showed this to him as a kind of homeschool art class. I did a visual thinking strategies exercise with him. I asked him the 3 questions you always ask in VTS. What do you think is happening here? What do you see that makes you say that? And what more can you see? He thought that it looked like that lady needed medical help and that she couldn't find the exit and she didn't know who to trust. And I think that's right. It's It's a very difficult painting. We can see that she's in distress. The anonymity of the figures, the neutral palette, the multiple intersecting perspectives, it makes it feel like whatever's happening is going to go on forever. This is what it felt like to live in my body after critical illness. I felt like I had a ticking time bomb inside of me. I never knew when a pain was another ruptured tumor or an eviscerating organ, or when my fatigue was really impending sepsis. The sequela of my admissions left me with terrible nightmares about drowning from all of that congestive fluid. I had intractable pain and frequent readmissions. I wouldn't have identified it as PICS or PTSD at the time. I just thought my body was broken. And keep in mind, I was literally on a tour for a book called My Journey from Death to Recovery and the Redemptive Power of Hope. And I was doing that in a body that felt broken and like it was going to implode at any moment. I was often having to cancel events for recurrent bouts of sepsis or emergency surgery. When I look back at that time, I sometimes think I thought I could trick my body into believing that I was recovered if I performed a version of recovery. What's ironic is that I was doing exactly what I was mad at medicine for doing, addressing one piece of the healing, the cognitive piece, and ignoring the more difficult, emotional, and spiritual aspects of the healing. I knew I had to go back in if I was really going to heal, and I went on a kind of re-embodiment quest for years. I needed to find something that was going to help me with that sense of estrangement from my body. I tried mindfulness and meditation, which was really helpful at letting me know how terrified I was moment to moment. I got deeper into art. I was trying to show myself that there were other ways of knowing beyond the cognitive, that you could experience things and know them. I even signed up for embodiment through puppetry classes. The most helpful thing I found was actually yin yoga, which, unlike some of the more active forms of yoga, really just involves finding a posture and settling into it, noticing the discomfort, but not reacting to it. It introduced me to the concept of interoception, cultivating a non-judgmental awareness about physical sensations. We didn't call the strong sensations pain because that would be attributing judgment to it. We just called them sensations. And that sustained, non-reactive attention changed how I was able to experience my body. I learned that not every sensation that I had meant that I was dying again. Of course, even the best medicine can't work if the diagnosis is wrong. So I kept trying to apply my new learnings in different situations. I developed a severe small bowel obstruction, which was something that happened not infrequently. And because I was trying to change my patterns of behavior, and because it was during COVID, instead of going to the ER, I decided I would just breathe through the waves of pain. I tried to think of them as strong sensations, though, not pain, because that would be attributing value to it. I impassively observed it. I noticed that it had the quality of strangulation, and yet I sat with it. In between bouts of violent, propulsive vomiting, I tried techniques to calm my body. I told myself things that were objectively true. I could allow the pain to exist alongside of me. I didn't need to tell myself a story about the pain. Perhaps this won't be surprising to you, but I was unable to meditate my way out of my small bowel obstruction. Turned out what I needed was an exploratory laparotomy and lysis of adhesions. I remember calling Tiffany afterwards. I was so frustrated. I was trying to learn to accommodate my body, and I still kept ending up in the same post-op place. And she said it sounded like my body was trying to communicate with me, pretty loudly, in fact, and what I needed to do was listen to it. She rightly pointed out that what I'd been doing was actually just looking for new tools to suppress and control what I didn't want to accept. And over time, I started to understand what these tools might be for. Like, they were really helpful for post-op pain. They couldn't make something that was true untrue, but they could help me soften to what was present. So if I woke up in the hospital, and of course they'd gone through the same incision again, and the pain felt exactly like when I was dying, I could use the techniques to message to my body that we were safe. I could notice the bed beneath me, the coldness of my breath. I could self-regulate my emotions and pull myself out of the panic. That was really our first moment of learning to trust each other again. This is a painting called Sick Girl by the Norwegian naturalist painting Christian Krogh. And it's believed to be of his younger sister, Nana, who died of the unremitting respiratory pandemic of their time, tuberculosis, which also took their mother. One day, about 5 years into my re-embodiment quest, in the middle of PH Clinic, a message came through my body. The message was, I'll be dead in 5 years. And I knew it to be true, even though I couldn't explain how I knew it. It felt so real to me. I didn't try to understand it. Instead, I just sat with it. Even though it was a scary thought on the surface, all of that practice being with myself meant that I could just sit with it. And I remember I was sitting in my office looking out the window with my morning coffee, and I could see the snow starting to fall, and it was starting to turn the grass white. And suddenly I didn't see snow falling anymore. I saw sheets of cells that were dividing, and I thought, right, it's cancer. I have cancer. And so we went looking for it, CAT scans, ultrasounds, MRI machines. I found the way that those tools saw things that were invisible to our naked eye, weirdly validating. Like we could trust things that came to us through vibrations of energy. We found the mass, we biopsied it, and it was cancer. And I didn't really feel the way that I thought I would feel when I learned that. There was the obvious grief, which was amplified by the fact that I had a young child. But there was also this sense that my body was trustworthy, and it was intuitive, and it was wise. The sick part of me was still me. It still wanted me to be well. Incredibly, I had never once thought of sick bodies that way. So this painting is by George Chicoteau. He's not only the artist, but he's also the physician that's depicted in the painting. And I find it so interesting that to paint this, you know that he had to observe this entire scene so closely. But when he depicts himself as the physician, he constrains what he allows himself to see. His gaze is directed solely at his fancy new technology. So I went back to the OR. They took pieces of my body away. It felt kind of like laying them at an altar in exchange for more time. I adapted to that pretty well. But then a few weeks later, I was told I would need a port. I had terrible access from years of critical illness. And I found I was having a really hard time accepting it. I did the thing that doctors do, where I went around the hospital asking everyone I knew who placed ports, nurses who managed ports, even patients who had ports, They're telling me I need a port because I have terrible access and I need infusions and frequent labs as a cancer patient, and I just don't know what to do. And every single person said, you need a port. Why are you even asking? And I didn't know. I didn't know why I was asking. So I called Tiffany. She had had lots of ports and dialysis catheters, and I knew she would get it. She asked me a series of questions that medicine didn't really have the room to ask. She asked me first, was it an aesthetic question? I really liked wearing dresses. Did I not want it in my chest wall? I didn't really care about that. She asked if it was an identity question. Was it that I didn't like what it meant? I didn't think it was that. I was getting used to my body. I said, I just felt like there should be another solution. And she said, well, that's it, isn't it? You're having to admit that all of this sickness came at a cost. And your body bears that cost. And she was right. And she told me that all bodies are worthy of love, even mine. So I got the port. And for a while, everything went fine until it didn't. The swelling was the first issue. Most days I couldn't see the bony structures in the back of my hand, and then my arm started swelling. I didn't read it as dangerous. I thought it was just another aspect of my body to accommodate and accept. I did the things that my doctors told me to do. I visited the lymphedema therapist. She measured me for a sleeve. We assumed that was the cause. I wore it every day, got an ultrasound to check for clots. The swelling progressed. I started holding the sunroof of my car when I drove home to let the blood drain down, and I would hold our headboard at night. In a fit of vanity, I downloaded an app that allowed me to shrink the size of my face in pictures because my head had started to swell. The swelling started to recede in the same way that it came, but unfortunately that coincided with my port not working. So I ended up back in the interventional radiology suite. And there, the interventional radiologist injected dye and revealed that I had this severe subclavian vein stenosis. This was the last image I saw before the sedation hit. The contrast was swirling through this, it looked like a stacked highway interchange. My body had grown new blood vessels to bypass what was a severe subclavian vein stenosis. I was overtaken by a sense of appreciation for my body, even reverence. It was so smart, it was so intuitive. While my doctors and I didn't know what was causing the swelling, even while we were ordering tests to try to diagnose it, even while the interventional radiologist was working to dilate the stenosis, while I was managing it with superficial solutions, my body was building new blood vessels. It didn't panic, it just quietly found another way to heal. I felt impressed by my own sick body, that it had managed to do something that medicine couldn't, and a deep appreciation for our intrinsic healing capacity. Laying there in the IR suite, even though I had all these tubes and wires coming off of me in a gown, I felt like a healer. Tiffany went into renal failure, and her hospitalizations were excruciating. She had severe delirium that was terribly distressing for her, these paranoid delusions about what was happening to her body. When she told me about her embodied experience of uremia, I was mortified. I'd been taught that uremia was a pleasant way to die. And I had counseled families on that in my own ICU. When I admitted that to her, she said that I'd been describing the death from my own point of view. A bloated but quiet patient slowly dying in front of me was not a burden to me emotionally. And easy for me should be easy for you. Like with most things, she was right. I'd been blinded by my own perspective. I had conflated my knowledge of uremia with what the patient's embodied experience of uremia was. Medicine can be a magical lens through which to view the human body. It can also be a terribly limited lens. I will always be grateful that Tiffany expanded mine. We lost her in March of 23. One last piece of art. So here we have what is a seemingly random assortment of objects. You might notice a shark, the piano, a Coca-Cola crate, a mannequin, a clock, a crucifix. From this angle, it's difficult to appreciate more than that. But if we were in that room and we simply shifted our perspective, if we let everything be what it is, but moved ourselves to change what we would perceive, this is what we would see. It's an incredible anamorphic sculpture of Salvador Dali by the French artist Bernard Prat. Perspective is a wonderful kind of alchemy that we have agency to choose. Reperception changes what we see, not because reality is changing, but because we ourselves are open to seeing differently. What I know now, subject to endless interrogation and revision, is this. Healing requires something different from us. It requires that we shift our understanding of sick bodies away from viewing them as broken objects that we need to fix. It requires us to view them as deserving of deep reverence, to accept that they each possess an intrinsic capacity for healing that we can barely comprehend. It requires that we view our patients as whole, with unique wisdom about their own bodies. When we do this, we move ever closer to becoming healers. We become healers. Thank you. Thank you so much, and congratulations.
Thank you. Thank you so much. That was a wonderful talk.